So, good afternoon or good evening. Welcome to another Igenomix webinar. The topic of today is the use of next generation sequencing to expand the newborn screening. And to discuss this interesting topic, we have as a panelist today Dr. Antonio González-Meneses. Dr. Antonio González-Meneses is neuropediatrician from the Hospital Virgen del Rocío in Seville. He is responsible for the newborn screening in the western zone of Andalusia, in the south of Spain. So, Dr. Antonio González-Meneses, you can start whenever you want.
Thank you very much, Jordi, and thank you very much to all the assistants that are today attending this webinar. It's been a pleasure. Could you, Jordi, confirm that my presentation can be seen?
Perfectly, yes.
Thank you very much. Thank you very much. Well, thank you very much, as I said, to all of you, and good evening. And these are my disclaimers. And I would like to talk about prevention. Newborn screening is something that we are talking about prevention. As prevention, we have several types of prevention of diseases. We have primary prevention, which avoid disease before it happens. Secondary preventions with early disease detection, which is what we do with the actual newborn screening test. And tertiary prevention, which is the treatment of an established disease in order to treat sequela. So we are going to focus on newborn screening, which, as I have already said, is a secondary prevention. And the problem is that most of the things that we are screening are rare diseases, and rare diseases are hard to prevent. And they are hard to prevent because the specific characteristics of rare diseases. They're low prevalence, below 1 in 2,500 newborns every year. Some of them are 1 in a million. Some of them are 1 in 100,000. The knowledge is spread, dispersed, and there's a small number of affected in each disorder, but they are not so low when we mix them. And there is also, for some of the diseases, a small knowledge in pathophysiology. Even though we have a success in early diagnosis with the newborn screening that was established around 1950s all around the world and on the next years, and most of the countries have newborn screening programs with hypothyroidism, metabolic diseases, cystic fibrosis, and immunodeficiency. And some other metabolic diseases could be amino acid, fatty acid diseases, urea cycle disorders, or lysosomal disorders. But the common characteristic of all these diseases to be detected in the actual newborn screening test is that all have biomarkers. So with the biochemical, from the biochemical point of view, we need a biomarker to do newborn screening programs using biochemistry. This biochemical diagnosis, most of the countries now do by tandem mass spectrometry with the detection of this abnormal biomarker and a confirmation afterwards with a secondary test. And we have passed from one test to multiple diseases. This tandem mass spectrometry has led us to detect as far as 40, 50 these different diseases with just one test, just one drop of blood. But unfortunately, not all diseases can be detected by tandem mass spectrometry, and that's what we are going to talk about. Even more, there's a great difference between newborn screening programs in between countries and even in the same country. For example, in the United States, we have federal recommended panel for all the countries, but some states have different screening tests. And also in the European Union, with a no common panel, we don't have a common panel in the European Union, and some of the states are using genetic screening. We will go forward on that topic. And there's an increase. We are increasing the number of diseases that we are searching now in newborn screening. Some countries or regions have are detecting lysosomal disorders, immune deficiencies, hemoglobinopathies, or some genetic conditions. So we are living a change on the reality of newborn screening. But as I said before, biochemical newborn screening has some limitations. Some limitation that it depends on its nature, as we need a biochemical biomarkers, and many diseases, they do not have it. Difficulties to establish prognosis in many cases, and the problem of false positives and false negatives. And sometimes we can detect biochemical profiles without clinical manifestations, which is a problem. Just to illustrate the problem of false positive and false negative, we have here that in Illinois and Missouri, screening MPS 1, right, we have more than 100 false positive just to detect 1 or 2 positive patients. So we have to bother and more than 150 families in order just to detect finally 1 MPS real patient. And that's a problem that can be solved by genetic testing. Rare diseases are far beyond newborn screening. I would like to bring you an example of clinical exome sequencing in more than 500 families in the Middle East, suspected with Mendelian diseases in Qatar. And as you can see here, we have these patients that they are from different ages, but most of them are children or under 18 years old. And I would like to take your attention that in this specific population, parental consanguinity is something that it takes more than 2/3, right? More than 2/3 of these patients with suspected Mendelian disorders are consanguineous, and there's a family history of 1/3 with that they already have family history of a disease, of a genetic condition. Most of the conditions are neurocognitive, neuromuscular, multiple congenital anomaly, or some others. And in this specific population, 2/3 are autosomal recessive diseases. In some other populations, only 1/3 are usually autosomal recessive population. Some of them can be X-linked, and some other are autosomal dominant. So in these highly consanguineous families, autosomal recessive variants accounted for the majority of identified causative variants. And even more, from these 509 patients, 11 cases had more than 1 genetic disease at the same time. So there are some specific population as it is in Middle East, but people from Middle East or some other highly consanguineous population are all around the world. Well, and we can see here some specific examples. Molecular genetics of phenylketonuria in Jordan, right? When we can see that there is a high rate of consanguinity and a high prevalence of tetrahydrobiopterin deficiency, to know that in PKU it's something very important because they have better options for treatment. And if we identify this specific form of PKU, we can put a much better treatment. And also with thalassemia in Gulf Cooperation Council countries, in this systematic review, with more than 3 million participants, the prevalence of thalassemia below 5 years is up to 33%, depending on the country. And the most reported risk factor were consanguineous marriage and high-risk marriage, which means that you marry with someone of your family. We have some more examples, like combined immunodeficiency, also in the Middle East. Middle East is an example of highly consanguineous family, and the median annual incidence rate is 4.5 per 100,000 Omani live births, and 91.7% of affected children were born of consanguineous parents when they have severe combined immunodeficiency. And that's a very, very severe disease with clinical manifestation with pneumonia, septicemia, chronic diarrhea, and a high rate of death in the first year of life if a stem cell transplant is not made. And although we do that, we have a 30% of a 27% of possibilities of death. So it comes newborn screening using genetic tools, which is the intention of this webinar. And what is that for? Well, newborn screening using genetic tools is the use of next generation sequencing for newborn screening. When we do newborn screening by next generation sequencing, we can virtually screen everything which is in our genome, but we have carefully to select what are we going to screen. We can center in few diseases, or in many of them, and can be a complement or can be done in parallel with biochemical newborn screening tests, which increase the resolution and the opportunities to detect for both techniques. This initiative of using genetic newborn screening is something that has already been performed, and I would like to show you this Chinese study. As you know, in China, there's a huge population. There are thousands of millions, right? And this specific study was done to detect hearing loss by genetic, and there was 1 million newborns screened for 20 hearing loss related genetic variants from 2012 to 2017. And if you compare, they compare in this paper the usual hearing screening test with this genetic screening test, and they detected a 13% more hearing impaired infants than hearing screening alone, and also identified more than 2,000 children, which was 0.23% of newborn predisposed to ototoxicity by antibiotics, which is very important because there is a specific mutation that can give us ototoxicity when the children is exposed to ototoxic antibiotics. So the conclusion is that incorporating genetic screening improves the effectiveness of newborn screening hearing programs and identify additional children that could benefit from early intervention, and also we can prevent the ototoxicity. So we are seeing with this, we can see with this work how the use of newborn screening by genetics can give us extended advantages. And also, we have some experience of newborn screening for with that German pilot projects on spine muscular atrophy. Spine muscular atrophy, it's a terrible disease, but it's the most common neurodegenerative disease in childhood. And the homozygous deletion in the SMN1 gene encoding the survival motor neuron protein is responsible in an autosomal recessive way of more than 95% of the cases. So the German had this pilot project to detect that prenatally, and that's important because we have a treatment. Nusinersen has been approved as the first drug for spine muscular atrophy in USA in December of 2016, and in the European Union in July of 2017. And which is more important, this study was performed from January to August from these years, 2018 to August 2019, and there were screened more than 165,000 newborns, and they detected 22 deletion in 21 family because there was one dizygotic twin pairs. And which is more important, we could also see the SMN2 copies, which is another gene that moderates or modulates the severity of the disease. And we can see that the patients with 3 and 4 copies are much more suitable of being treated with nusinersen. Also, there are genetic initiatives to test cystic fibrosis, and we can see how worldwide, in many countries, USA, also in South America and Europe, we have programs that are using actively genetic testing in the newborn screening of cystic fibrosis. That can give us values of a better diagnosis mainly. It can give us a reduction of false positive and an improvement of the predictive positive value. And it's better for those populations in which the usual delta 508 mutation is not the predominant. In the north of Europe, there's a specific mutation which it causes more than 90% of cystic fibrosis in the population. But as you change this population, you go more to the Mediterranean area or North Africa or some other population, these mutations expand, and delta F508 is not the usual or more frequent mutation. So it can give us a spectrum of these variants. To detect early these variants give us an early diagnosis and better access to treatment, earlier and more accurate, which is very important in this disease. So there are some more initiatives of genetic newborn screening. We have in Belgium, we have spinal muscular atrophy genetic testing that has been initiated in 2019 in Shanghai as a second tier after biochemical test to increase accuracy. Also in Norway, screening severe combined immunodeficiency in newborn screening. But newborn screening using genetic tools has some challenge, and it's nice to talk about this challenge. It's necessary to talk about this. The first is budget. Genetic newborn screening is it costs more money than to screen using biochemical tools. But this increased price can be optimized using specific tools to have automatic diagnosis, only screening the things that we want to see, and which means to screen mainly mutations that has been already considered as pathogenic. And the other important thing is what we want to screen. We will go further about that, the number of diseases that we would like to screen, and which diseases we would like to screen, and which diseases we do not like to screen. The other big problem is the interpretation of variants of unknown significance, and some countries or surveys, even in Spain, for example, which is something that I know very well, there's a lack of enough trained personnel in genetics. But also we have legal and ethical issues that have to be taken in account. So regarding these ethical issues, which are very, very important, there's a guide of ethical issues in pediatric genetic testing and screening, published in 216, right, in current opinion in pediatrics. And in this paper, they indicate that we should have an explicit informed consent and pre and post test counseling. That means that before performing this test, we should inform the family what are we going to test with diseases, how we are going to test, and what are we going to do if there is a positive of one of those diseases. And after the test is performed, we should give the family a comprehensive information and to inform of the results, which looks reasonable. With genetic screening, we have something that we have never had in biochemical screening, which is the possibility of detecting a carrier in a healthy children. That's important because, for example, in cystic fibrosis, we can detect that the children, which is healthy, carries a mutation, only one mutation instead of two, of cystic fibrosis. But maybe one of this mutation usually is inherited from one of their parents, but we have to be sure that the parent that has not given the mutation is not carrier of another mutation that is not being detected in the children, but can give this family, can put this family in risk of having another children with cystic fibrosis, following with the example. We could also detect diseases that are going to be manifested in the adult onset conditions. In my opinion, we should not screen for those kind of diseases. And we have to manage secondary findings, which are, for example, susceptibility to cancer or something like that, which are something that we should also take out of this specific newborn screening test. So, which will be the ideal genetic newborn screening use? Well, to my opinion, we should focus on these diseases, metabolic diseases, neurological diseases, deafness, immunodeficiency, hypothyroidism or thyroid deficiency, cystic fibrosis or severe problems with the lungs, and hemoglobinopathies. Maybe we could add some other diseases, but they should be relevant disorders with early morbidity and mortality, ideally with a treatment available, although that's not something absolutely necessary, and with a high disease burden for family, and which the three types of Mendelian inheritance, autosomal recessive, autosomal dominant, or X-linked. And I will do that in combination with biochemical newborn screening, which is, as I said, my opinion, because we are going, with this combination, we are going to accurate the diagnosis to diminish false positive and false negative, and to detect diseases much better for those that have a biochemical biomarker, but also we can detect anomalies that are purely genetics and they do not have a biochemical biomarker. We should do pre and post-test genetic counseling, which is something challenging in large population with a specific informed consent, and combining the results should be combined with parents' study in the case of carriers, because it's something very important. If you detect a carrier, that you can be sure that the family is not carriers of specific diseases. And in case they are carriers, we can use preconceptional diagnosis for future pregnancies. We should avoid, in my opinion, predictive disease unless there's a strong family history, and that's something that has to be talked with the family before given the diagnosis. And we have to be aware of the local laws, because, for example, this predictive disease screening is forbidden in my country, in Spain, and in some other countries in Europe, as far as I know. And there should be a fluid information exchange between professionals. So just for finishing and to be ready for questions, just the conclusions. Biochemical newborn screening is a very important tool for early diagnosis of rare diseases. Biochemical newborn screening has limitations and sometimes need a second-tier test, and many of these second-tier tests are genetics. Many rare diseases do not have a good biochemical biomarker, so we need a genetic test. In highly consanguineous population, there's an increased risk of recessive genetic diseases. And the early diagnosis of severe genetic condition can improve outcome in many of these diseases. And I think, and that's the main conclusion, that genetic newborn screening can be a very useful tool for the early diagnosis of rare disorders. Thank you very much for your, well, that's a view of my city, Seville, in the night. And thank you very much. And I'm ready for your questions.
So thank you so much, Antonio, for sharing with us your experience and for giving us this interesting talk. So we have some questions from the audience. So the first one is, in your opinion, which genetic tool we can use for the genetic newborn screening? Panel of genes, exome, and genome?
Well, that's a very nice and important question. And in my opinion, and that's something that can change in the future, I think that we should use exome, but extracting the information for selected diseases that we would like to screen. And the reason for that is that if we use genome, that can be much better. The price is going to be very, very high, right? And if we use panels, well, most of the panels that we use today, they are panels that are based on exome sequencing, and then by an informatic tool, we make a selection. So really, we should do exome, and then to select the specific diseases that we want to check, and also to avoid those when we are doing newborn screening tests. We should only inform about specific known pathogenic mutations. That's my opinion.
Thank you. Another question is, would you include the lysosomal storage disorders in the genetic newborn screening, and why?
Well, that's also a very, very interesting question. As a general answer, I will say yes. I will select lysosomal diseases, but the most important thing is which lysosomal diseases we should get into, right? As well, first of all, I will put in there those that we have treatment for sure. I will put them, but we have to be aware that in some lysosomal diseases we have some difficulty to interpret mutations, some mutations. So we should be very careful about that. But of course, MPS I, of course, Pompe disease, also those devastating diseases that, like Sanfilippo, I will for sure put in there, because in Sanfilippo there's some promising treatment that if you start very early, we can change the life of the children. But definitely, yes, some other like Tay-Sachs is something that for sure I will do, and New York is screening Tay-Sachs as far as I know. So definitely yes, and the most important thing is to select which one, which is something that should be talked about, right? The Australian has a very, very nice program, and I had the opportunity to be in a talk with them presenting that newborn screening initiative, and they said that they had to change the initial panel that they were using because of when you are using the panels, you see that there were some limitations on the diseases that they had screening, and there was a lack of some other important diseases. So yes, I definitely will check for lysosomal, but it will be important to check which ones.
Okay, thank you. But regarding the lysosomal storage disorders, there is any specific disease that you would not include in the panel?
Well, I have many doubts with Fabry disease, right? Because it's true that Fabry disease has a very nice treatment. Well, has a treatment that it has been performed for many years. But the initiative of genetic of Fabry disease in newborns, the problem is that we are not sure if if the anomalies that we are detecting are going to be pathogenic enough, right? And we don't know really when to start treatment. So I have some doubts with Fabry disease, and it's not only my doubt, it's something that is general, and that will be one of the most diseases that I will think very carefully what to screen.
Thank you so much. Do you think, another question is, do you think that the health system is ready currently to implement a genetic newborn screening?
Well, that's a very good question. I think that it depends. If we decide to start with hundreds of diseases? My answer is definitely not. If we should start with very few genetic diseases like SMA or cystic fibrosis, which is already been implemented, the answer is definitely yes. So you can do newborn screening from a genetic point of view as an individual decision, which is something that, okay, that's no problem. It's like doing a genetic test in some individual, right? So in that case, you don't have any problem. But if you are going to do it to the entire population of a region or a country, you need to be sure that everything works very well. So my advice will be to start with one or two severe diseases, right? From these one or two severe diseases to implement all the needs to make things work nicely, and then to progressively increase the number of diseases. That will be my option.
Thank you. We have another question regarding, can understand very well. Yeah, regarding the carrier status of newborn babies, we should inform or not, or in case of variants with unknown significance. What is your opinion?
Well, that's another very important question. Thank you. Well, my opinion is that I will not inform unknown significant variants. I will never in a newborn screening program, right? But if we detect a carrier condition in the children, the importance is not the children, it's the parents, right? So we should test the parents to see, as I said, with the example of cystic fibrosis. If we detect that the children is a carrier of a cystic fibrosis mutation, one of the parents is for sure the donor of this variant, right? But we are not sure if, let's say, the father is the carrier. Okay, we have detected that the father is a carrier, but we don't know if the mother is also carrier of the same or different mutation that has unfortunately not been given to the children. But we should check the other part of the marriage to see if they are also carriers. We have to have in mind that 1 in 25 European people are carriers of a cystic fibrotic mutation, and 1 in 75 of SMA mutation. So there are huge possibilities of detecting that. The importance is not the children, which is something that, okay, we cannot say to the children anything until the children is 18, but it's because of we can detect a recessive condition in, or maybe X-link, right? If we have a girl which is carrying an expansion of Fragile X syndrome, for example, or an X-linked disease, she's not going to have it, but the mother probably will be a carrier of this anomaly and mutation, and could have a boy in the next pregnancy that has the disease. So these are these ethical issues that we have to manage very carefully, and to have that very, very carefully, and to talk to the family if they want to know or not, which is very important before performing the test.
Thank you so much. Yeah, we finished the questions from the audience. I have another question to finish today, Antonio. Do you know any initiative to implement a genetic newborn screening in Andalusia or in Spain or any other European country?
Well, there are some initiatives. I put some examples in the presentations, and in Spain, for example, there are some initiatives to start screening SMA, right? Spine muscular atrophy. I think is going to be the next genetic screening implemented. And also there's a strong current opinion to use genetics as a complement of the biochemical screening at the same time. And these are the most near future changes that we are going to see in newborn screening tests in Europe in the next years. I'm sure about that. There are some countries that are already screening by genetic tools these absolutely devastating diseases. And I think it's a good idea. There's something very bad and we have a treatment. It's the ideal thing to detect and to treat.
Thank you so much. Okay, so thank you, Antonio. Thank you to the audience as well because of your attendance to this webinar. So we can finish, and that's all. Okay, so thank you so much.
Thank you very much to the audience, and thank you very much to the organizers for inviting me to share these opinions in this very fascinating topic. Thank you very much.
I think if some of you have any other questions, you can reach us. You can send us an email, or we'll be able to answer. Okay. Okay. So thank you.
Okay.
Bye.
Thank you very much.